Good afternoon, everyone. Welcome to the second AfroPHC policy workshop this year. And today we will be discussing the topic of exploring rehabilitation for PHC and UHC in Africa. So I want to welcome you all. We have with us today Prof. Shabir Musa, who is the AfroPHC coordinator who makes all these workshops happen. Welcome, Prof. Shabir. And with us today also, we have a speaker who is very seasoned in the work of rehabilitation. Normally, our workshops usually have a bit more people, so we usually have the structure is as follows. We have a speaker or two speakers. Then after that, we go into breakout sessions where we have a discussion, but we will not be doing that today. And I want to apologize for our French speaking colleagues because we will not have French translation today. So let's jump right into it. So our first speaker today is Marika the Swedenborg. Sorry, give me just a minute. So Marika is a physiotherapist who is qualified from the University of Pretoria in 2001 and has spent over 20 years providing and managing public sector rehabilitation services and in underserved rural areas of South Africa. She's a strong and committed advocate for disability rights, including the right to rehabilitation services. She is the co-founder of Rural Rehab South Africa and works with governmental, non-governmental, and civil society organizations on provincial, national, and international platforms to change policy and inequities in universal healthcare for people with disabilities and their families in low-resource settings. Marika was male and armed guardians 200 young South Africans in 2016 and individual recipient of a SAIPA award for community practice in 2018. Ruresa also received a SAIPA award in 2019 for their work in enhancing healthcare in rural communities. Marika is also a postgraduate diploma, also holds a postgraduate diploma in health economics and has completed coursework requirements for a master's in public health. Welcome, Marika, and thank you for making the time to be with us today. Over to you now.
Thank you, Mercy, and good afternoon to everyone. Thank you for joining us for what is very much a new area, and I'm excited that Rehab is getting this platform. This is my first time on this platform, so I hope that my presentation and the subsequent discussions are pitched correctly. I was unsure what the background of the audience was going to be, so please feel free to stop me if you want to ask, or we can discuss later.
What about quickly getting an introduction around the table? Do you think
that would be lovely, considering we're quite small. It's quite nice.
Mercy, you can handle that. I think just use your screen and ask people to call people out to introduce themselves and show themselves briefly.
I'm going to start with how you appear on my screen. We have expeditors. Please unmute and introduce yourself. Just a short introduction, who you are and what your background is and where you're working. Expeditors, are you there? Let's move to Robert Oyedipe.
You can all unmute yourselves directly, so just click and unmute and you should be able to speak.
Robert, are you able to speak? In case you're not able to, you can also just post something on the chat and we'll read it out. Blaise?
Yeah, I'm Blaise. I'm from Congo, Brazzaville. I'm holding the meeting from Brazzaville.
And Blaise, what's your background?
I'm a physician, medical doctor.
A medical doctor.
Yeah.
Pleased to have you here, Blaise. Eunice?
Thank you.
Eunice, are you able to unmute?
Sorry for I was on mute. Okay, my name is Eunice Koshomi and I'm attending from Zimbabwe. I'm a midwifery lecturer at the Women's University in Africa.
Thank you so much, Eunice. Pleased to have you here with us.
So yeah, so I do interested in primary health care with the women in childcare and the rehabilitation.
Welcome, Eunice. Senkire?
Thank you, Messi.
Senkire?
Hi, I'm Senkire Ephraim, a resident from Ghana.
Welcome, Senkire. And Senkire is also part of the AfroPHC executive coordinating team. Chwea Alex? Okay, let me move on to Funmilola. Oh, sorry, Alex, go ahead. Sorry.
Greetings. My name is Alex. I'm from Kenya. I'm a family health clinician who also works as a primary health provider and practitioner.
Welcome, Alex. It's a pleasure to have you here. Funmilola.
Oh, good afternoon. I joined from Nigeria, from Kogi State. I'm a nurse midwife with PNC, and I work in the Ministry of Health.
Welcome, Funmilola.
Thank you.
Marie-Claire. Okay, let's have Joseph. Please mute if you're not speaking, please mute so that we can hear everyone clearly. Joseph?
Good morning, everyone.
Good morning, good afternoon.
Good afternoon. I'm joining from Nigeria. My background is in medicine. I'm the lead senior fellow at the Africa Center for Clinical Governance, based in Calabar, Nigeria. Nice to be here. Thank you.
Thank you, Joseph. It's a pleasure to have you with us. Jana Mueller.
Hi, good day. My name is Jana Muller. Sorry, I don't know. There we go. Pleased to meet everybody. I'm from the Kwanda Center for Rural Health at Stellenbosch University.
Thank you, Jana. It's a pleasure to have you here. Abir Kamil. We're just having a round of introductions for those who've joined us. We are a small, close-knit group today, so we are having a round of introduction just to know who is in the room. Matthew, go ahead, yes. Matthew.
Okay, good afternoon, everyone. My
name is
Matthew Oladele. I'm joining from Minna, Niger State, Nigeria. I'm a public health professional. I specialize in area of health governance, accountability, and transparency in health fundings and financing. Thank you. I'm happy to be here.
Thank you, Matthew. It's also a pleasure to have you here. I don't know if there's anyone else who I missed who would like to introduce themselves. There's Pierrette. Are you able to introduce yourself? Okay, all right. Are there Diltoka, Gideon? Gideon, go ahead.
Yeah, can you hear me?
Yes.
Okay, good afternoon, everyone. I am Diltoka Gideon Kevin from Nigeria, with background in economics and in public health. I worked as a tutor with Ahmadu Bello University. Thank you.
Recording in progress. Welcome, Gideon. It's a pleasure to have you here. Now that we know each other and you know who is around the room, I'm going to give it back to our speaker this afternoon. Marika, please go ahead. In case you have any questions as she speaks, you can post them on the chat and we'll have a question and answer session when she concludes. Thank you.
Thank you. Okay, so I'm going to start off by introducing a little background to the topic, and then I'm going to try and tie in on grassroots applicable stuff, so that this is of relevance to people who are mainly policymakers, decision makers, health financing backgrounds, but also for those of us who are really at the coal face and needing to understand a little bit more pragmatically. So national health insurance is a vehicle towards achieving universal health coverage. It's a health financing mechanism which seeks to improve the coverage of the population with health services through progressive financing, better risk pooling, and strategic purchasing. Risk pooling is where the rich subsidize the poor and the healthy subsidize the sick. The bigger the pool, the more sustainable it is. The more pools you have, the greater risk borne by each pool. Reducing fragmentation also benefits purchasing power. The greater your market share, the greater your control over how much you pay. And this includes for goods as well as services. Being able to monitor system responses to inputs allows you to react appropriately, but requires a robust health information system. Overarching everything is the need for strong leadership, good governance, and civil society and stakeholder support. The overarching goal of universal healthcare is one of equity, equity in coverage of the population, equity in coverage of a basket of services, and equity in reducing out-of-pocket payments by its members. At this point, it's necessary to highlight two particular issues. The first is of quality. If quality is poor, people will either not use the service, even if it is free. They will either pay out of pocket for a service with perceived higher quality, or forgo the service entirely, or grudgingly have to use the low quality service sporadically. Either way, you'll not get the health outcomes you're looking for, and you risk impoverishing people further. The second issue is one of financial risk protection, which is typically measured through out-of-pocket spending at point of care, and rarely considers out-of-pocket spending on transport or income lost as a result of seeking healthcare. There's no blueprint for getting there, and whilst it looks logical on paper, it's rarely as smooth sailing in reality. Each country is different. They have different socioeconomic, political, demographic, and epidemiological profiles. Each country's health system is also unique. Each country's budget for health reform and the resources with which to work is very different. It's an incremental process. Success depends on a number of factors and requires strong leadership and sufficient stakeholder support, not only at national level, but at all levels of the health system. This is of particular relevance to disability and rehab sectors, as few policymakers, budget holders, and decision makers have any understanding of disability or rehab, and professional societies and end user groups are often poorly organized and fragmented. Beyond advocacy and stewardship, there are both supply and demand side challenges, which cannot be solved simply by throwing money at disability and rehab. Sure, it'll help in some way, but it won't completely solve the problem, which brings us to service design and delivery. The way services are designed and delivered has a massive impact on uptake and retention in care, largely because it affects affordability, acceptability, and accessibility. But to do this well, and here comes the crux, And to do this at scale, you need robust health information systems, which give you sufficiently detailed and disaggregated information with which to make informed and strategic decisions, as well as to manage services on a day-to-day basis. We simply cannot get away from it. Monitoring and evaluation, whatever level you operate at, be it national, provincial, district, or local primary healthcare, you need to know where you're coming from, what you're aiming for, and how you are doing. You need to know how the system and its end users responded to different interventions. Otherwise, you run the risk of getting stuck in a rutted track and getting the same mediocre results. At national level, policymakers and budget holders want to know what gives us the best bang for our buck. This is the realm of health technology assessment and economic analyses, and has implications for collaboration between academia and coalface workers. Are we getting bang for buck? For example, is it worth contracting a practice to provide a certain number of interventions if you, as a payer, have no idea how many people require them and have no idea what fraction of the population receive them? And how would you know whether those interventions you're paying for have had an impact on, say, poverty levels for a specific subgroup of vulnerable people? Is it equitable across these subgroups? Are we leaving someone behind, or does it cost any group proportionally more to access the services they need? And finally, what progress are we really making towards universal health coverage? At grassroots level, you want to know, how well are you doing? How well are you performing for service X? Who do you need to see? At what frequency do you need to see them for services X, Y, and Z? Who's waiting for that assisted device? Do you need more staff? And what is your loss to follow-up rate? To monitor progress towards universal healthcare, two discrete components are measured: coverage and financial risk protection. This is done using a number of information sources, including national census data, routinely administered national household surveys, and routinely collected health service data. It's also supplemented with contextually relevant research results where necessary. But the devil is really in the detail. Things may look great at macro level, only to find that a particular subgroup of vulnerable people are being left behind. But to analyze this, you need sufficiently disaggregated data and a large enough data set. And of course, it also matters what questions you ask and who answers them. And this is really where rehab and disability is falling through the cracks. Rehab services across Africa are fragmented, underfunded, underdeveloped, and, if they exist, largely centralized to bigger institutions. The vast majority of rehab services available rely on out-of-pocket payments. At the point of care, this is driven either by a fee-for-service model or through insufficient insurance coverage. And due to the highly fragmented and centralized setups, also through out-of-pocket spending on transport getting there. Human resources are limited both at professional level as well as mid-level rehab workers, and there's little evidence of a robust workforce planning. As I've said before, there's little understanding of disability in rehab by budget holders and decision makers. And if disability in rehab is even given a chance for policy input, it's often at the final stages with very little chance for meaningful input. What advocacy and integration efforts exist are often hampered by global lack of relevant data. All in all, we haven't really got our right foot forward, and a collaborative effort is going to be required for progress to be made. Why is rehab so historically poorly developed and integrated? Well, there are a number of reasons, largely around what data is used and how analyses are done. And this is going to require some creative thinking in the future in order to mainstream disability in rehab for inclusion in health benefits packages and monitoring universal health coverage in particular subgroups. But it also has to do with what the objectives of the health system are. Most are still focused on infectious diseases and mortality, and have historically been driven by donor agendas. Whilst this seems to be changing, the wheels of bureaucracy turn slowly. Lastly, and most poignantly, it really is a case of out of sight, out of mind, where a proportion of your target population doesn't appear on any service utilization registers, cannot effectively complain or lobby, cannot be analyzed as a subgroup in health service analyses, where rehab services are so fragmented or non-existent that even if people were aware of them or wanted to use them, they couldn't. And where relevant data doesn't exist, then you have the prime recipe for neglect. And yet, people with disabilities, although not a homogeneous group, are largely understood to have the same general health needs as others, but with far greater barriers to accessing and remaining in basic healthcare, additional specific health needs relating to their disability, and a higher risk of additional health conditions developing. And yet they are consistently left out of health policy and planning and glossed over when discussing universal health coverage. As previously mentioned, there are both supply and demand side challenges to providing effective disability and rehab services. These are well described in a plethora of qualitative literature, yet quantitative analysis is severely lacking. And whilst service design and delivery has the potential for influencing many of these barriers to uptake and retention in care, it's sadly not as simple as preventing impoverishment, addressing HR, ensuring geographical coverage of services, ensuring assistive devices are adequately funded, providing evidence-based health sector interventions according to stipulated clinical practice guidelines. These are all really important, but they are just pieces of a puzzle. I'm going to relate 4 stories, each of them touching on an aspect of service design and delivery, which has the potential to affect uptake and retention in care. Over the years, I've heard therapists and managers often say the following: we don't need any spinal cord peer supporters because we don't have any quads or paras. We only have 20 to 30 children with CP in our area, so we run a group at the hospital once a month. We only need 1 physio and 1 OT because we're a small district hospital and they easily manage the OPD and the ward work. We don't need a rehab team at each hospital or CHC. We can bus the patients to the nearby institution once a month for assistance. It's the parents' responsibility to make sure they bring their child. We're not going to chase them. We offer a group monthly at the hospital, but they just don't come. The people are there, they exist, but for numerous reasons, they are simply not accessing your service. The barriers have been very well reported, yet it seems as if this literature goes in one ear and out the other when designing, resourcing, and implementing services. So, you have a monthly income. This also may be called consumption. After you've spent it on food, you have a portion of it left, some of it which needs to go to healthcare. This is your capacity to pay. You'll be able to spend up to a point on healthcare, after which it will become unaffordable for you. This is your threshold, beyond which your spending is considered catastrophic. Either you will borrow money, or you'll have to sell assets, or you will simply go without healthcare. This is then your choice, and it will be a balancing act between affordability and acceptability. Universal healthcare supports the principle that people are able to access healthcare based on need and not their ability to pay. Central to UHC are the concepts of financial risk protection and equity. Financial risk protection is monitored using population surveys and routine health service data, but, as we've said before, typically considers cost to the patient at point of care and does not include transport costs in getting there. Thankfully, there is a growing movement amongst health economists to lobby for the consideration of transport costs in calculations, as studies have shown that this can contribute up to 70% of the costs of seeking healthcare in sub-Saharan Africa. In striving for equity, analysis of subgroups within the population is critical. For example, in South Africa, it's estimated that a mere 1.4% of the population experience catastrophic health expenditure when seeking healthcare, if the threshold is set at 10% expenditure of per capita income. However, is this the same for people with disabilities? How much more or less do they forego healthcare because of financial constraints as opposed to availability and acceptability of care on offer? We don't know, because this level of information is not available. The aim of universal health coverage is not to have people land up with catastrophic health expenditure. But without being able to measure it in the subgroup, we can never honestly say we're making healthcare more universally accessible. It also means that we're doomed towards making the patient fit the service rather than designing the services around the patient. And where resources are limited, this is a very tempting option. Tired of singing the same song of the raised costs of transport for people with disabilities in accessing services when we were requesting resources required as our care, our little rehab team decided to try and quantify it. Focusing on cerebral palsy services, we used real service intervention data post-COVID reforms, as well as reported household demographic and service information gathered during routine household screening and baseline rehab assessments for 80 surveyed homesteads. We then calculated an estimated catastrophic health expenditure per capita using welfare grant income as a proxy for consumption data, and used rehab service stats as a proxy for frequency of care required, and reported household transport expenditure in accessing clinic and hospital services when honoring a CP service appointment as a proxy for expenditure at point of care. We used an accepted formula for ascertaining per capita out-of-pocket expenditure. Using actual intervention data, we modeled this for cost to patient for services offered primarily at home level versus primarily at clinic level versus primarily centralized to hospital, keeping any service data delivered at hospital level, using the assumption that referrals upwards under the current community-based model was for unavoidable reasons. At the 10% threshold, 1.4% of South Africans are expected to be pushed into catastrophic health expenditure in accessing care. Under our calculations, albeit with a number of explicit assumptions, 8% of households with a child with cerebral palsy would be pushed into catastrophic health expenditure, even with the current home community-based model. 18% should we run the majority of services at clinic level, and a shocking 49% should we have to centralize services to district hospital level. The way we design and deliver our services has a big effect on the affordability and acceptability of services. Placing the responsibility on the patient and their family to access a scarce service in a broken system repeatedly at a cost that is likely to impoverish the whole family, and in a current service with highly variable quality, reliability, and outcomes is hardly reasonable. Transport is a major driver of out-of-pocket expenditure in accessing health for people with disabilities, even more so than those without in low resource settings. Access to, expenditure on, and capacity to pay differs across families, and it's not directly proportional to distance from health facility. Poverty, disability, and unmet need are entwined. More attention to subgroup analysis is required. This requires improvement in health information systems, including population surveys, as well as routine rehab data collected. And finally, this was simply a grassroots exercise in quantifying inequity. Formal quantitative research is required. My second story is about using a crisis well in order to initiate some key reforms at grassroots level. South Africa entered into a sudden, severe, and prolonged lockdown in response to COVID that had significant socioeconomic and social consequences. Additionally, service delivery disruptions and a tendency to centralize services when they were available worsened access, including in the health sector and particularly for the poorest. Little guidance was given to rehab staff regarding how to restructure and prioritize their services to protect the most vulnerable subgroups. The majority, under pressure from an institutional management, centralized their services and cancelled outreach. One particular service did not. This rehab service is attached to a medium-sized rural public sector hospital situated in far northern South Africa. Its multidisciplinary rehab team provides generalist services across inpatient, outpatient, clinic, and home community levels. It works collaboratively with local donor-funded NPOs, including those providing peer support services. In light of the profound socioeconomic impact that severe lockdown was having, this rehab team took stock of its current approach to service delivery and the capacity for reform. The team made the decision to shift all moderate and severe disability services from clinic or hospital to homestead level. This required the team to address key governance issues, engage in more task sharing, amalgamate various previously separate patient databases, engage in explicit priority setting exercises, and develop an electronic patient management system to coordinate the types and levels of care required. The team conducted baseline needs assessments at each home visit. Particular emphasis was placed on tracing of priority patients previously lost to follow-up, which was found to be strongly correlated with household income poverty and transport costs in reaching health facilities. Strengthening the integration of peer supporters into the Rehab team brought a critical end-user perspective to service design and delivery, and improvements in integration of Rehab services into existing primary healthcare structures strengthened the sustainability of the approach. High levels of unmet need, inefficiency, and poorly coordinated care across all areas of service were found. After 1.5 years, the team embarked on a series of program audits to assess the outcomes of the new reforms. Within the cerebral palsy services alone, in the 0 to 5-year-old category, service coverage had increased from 58% to 78%, with children now receiving an average of 6 sessions in 6 months, rather than a single rehab session every 6 months. Similar outcomes were found across other age group categories. The average age at which a child with cerebral palsy received their first seating device improved from 4.4 years to 2.1 years, and the wheelchair coverage rate for the 0 to 5-year-old category rose from 32 to 83%. Before the reforms, seating reviews were not conducted for the 0 to 5-year-old age group at all, but at the time of audit, 64% had received 2 or more seating reviews within the last year. 35 children previously lost to follow-up were brought back into the system. These changes represented a significant increase in coverage, skewed towards those with the most difficulty accessing healthcare services. They arose from improvements in data management and coordination of care, increasing the involvement of end users in service planning and delivery, and a focus on decentralizing care to community level. Whereas previously the onus was on families to attend appointments at a health facility, the new approach made the team proactive in following people up, in coordinating care across professions and across services, and in working holistically within the individual in their home context. While the reforms were not specifically aimed at improving cerebral palsy services, this program reflects the positive effects experienced across the Rehab service due to the system innovations. Again, be aware of your assumptions. Without sufficient data, they are just that, assumptions. My third story has implications about how we practice, but also questions about what we will cover for the outcomes we want, as well as what reimbursement approaches we will use. Ms. X was born into a traditional family who lived in a very rural area, far away from even the closest clinic or road. Because of where she was born and what life prospects were available, Ms. X never obtained a birth certificate or an identity document. She was a wayward teenager and soon found herself pregnant with her first child. After the 5th child was born without her having an identity document, her father put his foot down and told her he would accompany her to the closest home affairs, 3 hours away, to start the laborious process. That night, Ms. X ran away to the city, where she remained for many years. Eventually, she became critically ill. Her dubious employer put her on a taxi and sent her home to her rural family, whom she had not seen for many years. She was admitted in the local hospital and discharged home with a poor prognosis. She had TB meningitis and TB spine. Because she had no birth certificate or ID, she could not access any welfare grant, and the family of 5 adults was already trying to survive off a single old age pension of 1,900 Rand a month. Almost immediately upon returning home, her indwelling catheter became blocked and the family had to pay another 500 Rand to hire a vehicle late at night to take back to the hospital. This happened several times. Furthermore, in attempting to apply for a birth certificate and ID at the Home Affairs office 3 hours away, they had to hire a vehicle at 3,000 Rand a trip because she could not use a standard taxi. This involved borrowing from loan sharks. After 3 failed attempts at this, the family threw their hands up in the air and said, "Enough is enough." Ms. X was considered a curse and was denied further financial or physical assistance, although she was allowed to continue to reside within the family homestead. Because of where she lived and because of inadequate information systems and case management at the local hospital, Ms. X had been lost to follow-up. During COVID lockdown, after amalgamating several databases and prioritizing those lost to follow-up, Ms. X was miraculously traced. Amazingly, she had not developed pressure sores or renal failure as a high paraplegic, despite no bladder or bowel management or rehab input. However, due to her TB meningitis, she had severe upper limb ataxia and was unable to perform even simple tasks such as shelling a peanut or buttoning her shirt. She was also unable to sit up without support, roll over, or perform any self-care task. She was severely deconditioned. The rehab team noted that every time they entered the homestead, the other adults would give them a cursory greeting and then just disappear. The only adult who took some interest in assisting with the rehab sessions was a neighbor. Despite collaborative goals having been set, and despite additional funding having been raised to purchase Miss X a bed to make transfers easier, monthly food parcels for the family, cement ramps and paths to be built, and a borehole sunk in the yard, the family remained distant. These donations were temporary, and having not seen a health worker for a few years, they had little faith in continuity of care. Miss X was then admitted to a hospital for 2 months of intensive rehab, into which she threw her heart and soul. Upon discharge, she was able to dress and wash herself, do a single-level transfer between wheelchair and bed, propel up an incline, assist with preparing food, and able to self-catheterize herself. On a follow-up home visit, it was found she had regressed back to baseline. Her family were not interested in assisting her to become more independent, and she remained sitting on a grass mat, not even in her wheelchair, in her own urine, day in and day out. The rehab team, unwilling to accept defeat, yet acknowledging failure, liaised with Home Affairs officials, partnered with a local NPO, and personally transported her to her Home Affairs appointments. After a full year, Miss X finally had a birth certificate and an ID and a welfare grant. 6 months after obtaining a welfare grant, Miss X had started to build herself a one-room, was able to voice her opinions and make her own decisions within the family, was able to propel herself over sandy terrain and use her water pump independently, as well as dress herself and manage her own bladder. As a contributing member of the family, now on a sustainable basis, she was finally given the due respect and support. The moral of the story is that the best interventions in the world amount to naught if family support and basic prerequisites for engaging in rehab are not in place. Sticking to a narrow medical model or within the mandate of health will rarely give you the outcomes that are desperately needed and may even contribute towards wasted expenditure. Whilst it's all nice and well to say, refer to Home Affairs, refer to social worker, access to much needed documentation and government services may be well beyond the financial and social support means of the very people who need it the most. And often as a rehab worker in the field, you find that the responsibility falls on you. This has implications for rehab workforce planning, as well as benefit packages, contracting, and remuneration strategies. And lastly, this client would most definitely remain lost to follow up without sufficient information systems, explicit priority setting, and active tracing. My final story is around managing assistive device budgets to make ends meet on the ground, effects of centralizing care and analyzing subgroup responses, as well as in incorporating end users into service delivery. Budgets will never meet the need, and creative ways to keep costs low without compromising access to care and appropriateness of the device must be found. Every year, this department receives a wheelchair and accessories budget of between 80 and 400,000 Rand, of which, due to procurement challenges, only about 75% is ultimately spent. However, projected need is conservatively around 800,000 Rands per annum. This shortfall must be made up in a few ways. Firstly, by treating wheelchairs as a pool rather than belonging solely to a single person for a device lifespan. Secondly, by fostering a strong community footprint and incorporating wheelchair users as wheelchair repairers and peer supporters, thereby facilitating retention in care through follow-up visits. Thirdly, through regular decentralized wheelchair maintenance, repair, and reseating services. And fourthly, through supplementary donor support. This is data depicting the number of follow-up seating reviews per category of user over a number of years. It's not a seating rate, as this would require a denominator per category, and this still requires further refining of our databases. This rehab department had offered 5-day-a-week wheelchair repair service since 2004. It attracted mainly users from the immediate surroundings, apart from the odd client from a remote area who brought in a severely broken wheelchair for repairs or replacement. Because of a lack of training, wheelchair seating reviews were not conducted. In 2015, a few therapists attended postgraduate wheelchair seating training. Additionally, the wheelchair repairers were trained as peer supporters. The wheelchair maintenance, repair, and seating review service was decentralized to clinic level, and attendance was facilitated in advance by the wheelchair repairers phoning their own clients and alerting them to the dates. Attendance spiked in all categories. Wheelchair skills and counseling were added to the services offered at these outreach clinics. Sadly, in 2017, the lead therapist was transferred to National Department of Health for 8 months, during which time wheelchair outreach clinics stopped. Adult advanced users, who are those with the most severe postural deformities requiring specialist seating interventions, remained in care only because they had the cell phone number of the lead therapist and were willing to travel in for the service and made a booking to see her on the occasion she returned to base hospital during those 8 months. And then came the car crises, stockouts of cushions and spares, and some internal governance issues. Eventually, all categories dropped off, even though the wheelchair service was still available 5 days a week at the district hospital. COVID was the final nail in the coffin. Thankfully, the team chose to decentralize services to homestead level. This identified many seating and repair issues, which were addressed accordingly. Intermediate and advanced reviews, the categories which are the most concerned about, rose exponentially, well beyond levels reached during the clinic outreach. However, basic low active and basic active user reviews rose, but only slightly, and resuming clinic outreaches between waves must urgently be done. Besides the essential role that end users can play in delivering a service and the critical need for seating training for therapists, if they are to meet the needs of the community, this data highlights the profound effect that small changes to service delivery have on retention and care for those with moderate and severe disabilities. We need to move beyond measuring wheelchair issuing rate as a proxy for access to care, and towards seating review rate or wheelchair repair rates as a proxy for quality of care and retention in care. And lastly, it drives home the point about disaggregated data and subgroup analysis. The challenges facing disability and rehab are many, but can we address them in order to truly drive universal health coverage forward for those who really need it the most? Thank you.
Thank you very much, Marika, for that wonderful presentation. Let's give her a round of applause. I'm sure I was seeing the comments on the chat as we were going along. Everyone loved the presentation, and there were a few reactions. Because when you talk about the issue of people who are left behind by our systems, a lot of people who are suffering from disability are amongst those who are left behind. And so welcome everyone, those who are just joining us. Today we are looking at exploring rehabilitation services at the primary healthcare level. Mercy Wanjala, a family medicine resident from Kenya, your facilitator today. So right now we are going to move into a question and answer session. I did not see any questions in the chat. So if you have a question or a comment, please feel free to raise your hand and you can unmute and ask your question or make your comment. We have Osden. Go ahead, you can unmute and yes, thank you.
Thank you very much. I just want to ask while we are talking about disabilities, I saw that the wheelchair usage has been just fall down in the charts. So can we talk about the disabilities and also domestic violence in here? Have you got any evidence about that, if the lockdown has affected this? Because it is again another disability that we couldn't reach. Thank you very much. And also, Karen, it was just a great presentation to see, and it was evidence-based. Thank you very much.
Thank you. We haven't, that's not an indicator that we have been monitoring. However, it will come up in the clinical notes. What I can say from our mental health care services is that we would routinely monitor readmissions to hospital for people who had relapsed. And through a lot of health systems input over the years, we'd brought that down to 3 readmissions per month. And that rose to 9 readmissions per month during lockdown. And we're a very small rural community. Definitely, for sure, there has been a rise in domestic violence as well as in mental health care in general.
And my second question is for Karen and also for the other audience, the participants. What could be the measures or options to strengthen family physicians and healthcare workers in rural areas for gender-based dimension?
Sorry, can you repeat that? What am I understanding? What would be the human resource strategy for strengthening a response?
Yes.
A lot more mental health care services for rural healthcare workers themselves as well. Counseling, debriefing, access to training and trauma management as well would be particularly helpful. We struggle with a responsive justice system here. So going through the formal channels with perpetrators is often a frustrating and futile exercise. We have traditional authorities as well. Sometimes there is community responses to it, but all too often there isn't. I don't know how to fix this justice system, I'll be honest.
Thank you, Ozden and Marika. You've raised quite important points and also stimulated quite a lot of thought and discussion, because there are a lot of issues surrounding UHC, PHC, and especially the vulnerable groups. And I like how you have brought up the issue of start with the carers. If you want to strengthen the system, start with the people who are working within the system. Prof. Shabir, please go ahead.
Yes, thank you, Marika. That was really wonderful insights that you gave us. And I really appreciate that you took it on from a systems point of view, particularly looking at the finance. I think as we're going forward in the AfroPHC and try to put documents together to support appropriate primary health care universal coverage, that's going to be a particularly important issue. You know, politicians always look at the money issue very quickly, and we need a very strong evidence-based, resource-informed approach. So I really like that. If I can ask you, I think you've given so much of valuable stuff. Just to tell the audience that we have in fact I have put the presentation as a PDF on the website. So the same page you've seen as the advert. So you go to the front page, you just click on that advert or the graphic for the workshop, and you'll get to where the details of the actual presentation is. The recording will be there in a few days, and then even Mariki's text is there as well. So she's been kind enough to share it. What I'm curious about, Mariki, is the question of, we understand the whole challenge, the question of access being denied. And you've also pointed out, the difficulties around rehabilitation. It's often less of priority because people see it as, more indulgent almost. Yet we know that it is in fact a very important part of primary care. And one of the key questions lands up being, how do you find a way to manage those demand supply issues, and particularly the supply challenge, where in Africa, can we talk of human resources to address universal coverage, where there's, like doctors, for example, they say there's just net shortage and we cannot possibly reach out. And so it becomes very much, take this thin butter, spreading it isn't worthwhile, so keep it in these centralized spaces, partly because clinicians, it takes a special person to do some of the things you've pointed out. And it perhaps takes a good system, but, given the difficulties, we'd have to understand, well, what can we do in system, but also how can we create the kind of people who you shared in that example in northern, I think was it Limpopo, where you shared, how they've been able to achieve some really useful results. But I'm curious as to how they organize themselves, particularly the task sharing. And I don't know whether they dealt with it in a way that took a population of people into account, whether that a sense of this is the number of, physios, other rehab professionals, and they delivered a service like you described to a defined population. And was that evident in that process? That's my first question. And how did they actually put the mix together of the different cadres, including community health workers, which are there? How did they put that all together? And population-wise, how that came out? And then the other question I have is I didn't quite understand the sort of catastrophic health expenditure when you talked about those bans and the current clinic and centralized hospital models, and what that meant. When you said CHE estimated 1.4, I didn't quite understand that slide. So I don't know if you can share those two. I might have some others as we're going along. Thanks.
Okay, I don't have a pen on me, so you might have to just prompt me on your 3 questions again. But with regards to the HR crisis, there's never going to be enough therapists to provide the care that is required.
Yeah.
If we stick to I want to be rude and say a private practice one-on-one model,
Right.
with an individualistic approach.
Mm-hmm.
We need mid-level rehab workers. We need people with disabilities themselves as end users, not as volunteers, as staff.
Yeah.
Formalize it.
Would you call them CHWs or would you call them differently? I mean, can we utilize community?
It doesn't really matter what you call them, but it is rather the qualities and backgrounds that you are looking at in selecting them. And I think, I've done a lot of work now with peer supporters and parent facilitators. So parent facilitators are mothers of children with cerebral palsy. And they are champion mothers that have shown themselves to go beyond and to be kind of role models. Peer supporters typically are within the spinal cord injury category, and have also shown they're individuals with high levels of integrity, high levels of passion, self-motivation, that have also shown themselves to be role models within their communities. And I must say peer support and parent facilitators have changed our services completely. And I don't think that they are, you can't substitute them with another mid-level rehab worker because they carry legitimacy. They've been there, they have done it, they know what's going through someone else's brain that's in the same predicament, and they've risen through it and gone through it. So they're particularly critical, like with newly acquired disabilities or with a new child with a disability, etc. Your head is not right. Your life has stopped. Everything's fallen flat. Everything that you thought was going to happen in the next 20 years is just, it's not going to happen anymore. And no health professional is going to pull you through that. And we were seeing a lot of mothers just coming with their children and just giving them to the therapist and then sitting quietly and playing on their cell phones or disengaging, etc. And that's really a waste of a therapist's time. It's a waste of the government's money. It's a waste of a lot of things. Buggies that weren't used, like wheelchairs that weren't used. We were seeing a lot of spinal cord injury patients with pressure sores that were refusing treatment, refusing advice, etc. And with peer support and parent facilitators, they've really managed to win the heart and soul, and then the rest follows. And that for me is critical in making it work. The other bang for buck that you get from peer support and parent facilitators is that they grow a social network second to none. So if you want to identify people that are typically hidden within the community, or people that have clocked out of the system or been dropped by the system, this is the cater that really can build that network for you. And so when we run our wheelchair outreach clinics, if I had to phone the guys and say, hey, be there or be square, I'll be at the clinic on this day, come with your wheelchair, I wouldn't get half the number of people. But because it's my wheelchair repairer who is also a wheelchair user and they know him and they trust him, people will be there. So for me, a lot can be done with end users and the inherent qualities that they have and that they can offer. But you need to formalize that system, and they're going to need pre-voc and ongoing support and training. You know, what you get what you sow, you know? So what you put in is what you get out. So I think that that's got a lot of scope for piloting.
So it's about roles. I mean, it's about task sharing, task shifting.
Yes, and it's about working collaboratively with them. So I get early referrals, early warning systems back from my peer supporters. The client would rather phone them than phone me, and definitely will not spend the money to come into a facility for a problem. Phones my peer supporter phones me, says, hey, this is the problem. And I'm like, okay, cool, dispatch a team. That's serious. We need to get this person in. So, yeah.
So if I can quickly direct you on the question.
There's a lot of scope there.
Yeah. In that setting, is that what they've used? The one that you quoted where the sort of 3 years later, the Cerebral Palsy program, is that essentially where it was a program which involved this kind of mix?
Yes. So
what was the population?
So there's 135 children with CP under 18 on the books. There was a parent facilitator in 2018 and 19, a single one, but because she was not fully supported and she had not been integrated properly into the rehab system, she did work where she could, but that kind of like task sharing and complementary work wasn't really happening to the max. And then in 2020, we added 2 more parent facilitators to the mix, and then formalized the program, got them stipends from donor organizations, put in a lot of work around. They formed their own NPO. We looked at governance issues within the NPO, like basic work training, work hardening stuff, additional clinical training, etc. And since then, yes, the results are not solely because of the parent facilitators, but without them, we wouldn't have got those results. No, the results also were around the information systems, the way we reorganized our teams, the way we prioritized, the way we forced people to look at the data and like manage cases.
Perhaps I can just quickly, in sort of wrapping up and letting other people speak, because there are quite a few other questions popping up and comments you can respond to. One of the key, and it's something we can do more research on. One of the key problems in UHC is, in fact, when the funding occurs, it tends to be based on population, to say per capita, this is the cost of X service with this kind of impact and actually value. This becomes the language in terms of UHC discussions. And I think it's something that one really needs to, I think, the concept is really important, but we need to do more research around population-based costing of care, looking at the mixes of, configuration of staff like you're looking at, and what the cost is and what the impact is and what that adds up to actual value to the population broadly. I think that's just a thought.
Absolutely. I couldn't agree more.
Anyway, thanks for that. Over to you.
Sure.
Yes.
Thank you so much. There's so much coming out of this Q&A and the discussion, and things that I think we've neglected for so long and we don't look into and we really need to look into. Joseph has a comment and I think a question, or why has Africa missed the fact about UHC? And I think this is coming out from the structure that you laid up, Marika, as your beginning, what UHC looks at and the different facets we need to look at as we are setting up the systems. So, and he comments that countries that have functioning mandatory health insurance achieve UHC, while countries that do not have the whole population health insurance do not have UHC. Maybe you can comment on that.
Perhaps I can give that comment to Prof. Musa to answer.
Yeah.
Wasn't completely paying attention, so you may just repeat it for me.
Oh, no.
The question.
Okay, Joseph Anna is asking, why has Africa missed the fact about UHC? And he comments that countries that have mandatory health insurance for the whole population have managed to achieve UHC, but those that do not have insurance do not achieve UHC.
If I may respond to that, I think the problem is that health insurance in itself is a concept that's coming out new. And I think implicit in the idea of insurance is strategic purchasing. So mandatory health insurance in Africa has been a challenge where at the moment the tax base has been used very much based on that. Aid money comes along and then there's fragmentation. There isn't enough money within the economies of African countries to be able to lift that access broadly across. That is, I think, a real problem. So there is a problem of, we can say it should be, but it's a funding issue at the end of the day. The mechanism of health insurance, on the other hand, is a way to achieve more efficiencies in the process, where I don't think that whether you take that tax and put it into budgetary current financing systems, you will get much more from the private sector or those, unless you actually match the private sector. So I think mandatory health insurance is struggling across Africa, and many a times the UHC attempts are fragmented. So, for example, in Kenya, for example, there is this attempt to make it broadly applicable, but the real change is the way in which the funding occurs, which is strategic purchasing. You still get a private sector, and I think the governments in those places are struggling to lift the ceiling on the money to extend it to the entire country, because the gap between public and private is so large. And I think this is a problem everywhere. So it's probably a net, two factors. One is a net lack of money, which is a global problem. The world needs to understand if they want social solidarity, they need to add more aid money than they have. And it shouldn't come dictating their priorities. It should come into the fiscus of the country, and they should help countries set up systems that make for much more efficiency, which is strategic purchasing. And I think this is the language that we need to put forward. And what the problem is that, the money is not just going to come. So what we've got to do is to advocate that system, but probably based on a much more resource starved situation, where we say, yes, you can still apply it across the country, but it is reachable. And there are different countries, different situations. So in South Africa, for example, you might get one doctor to 10,000, but we want to ask the question, well, can you not get one doctor to 30,000 in other parts of Africa? And you could. That still gives leadership. It's the same, for example, with a rehab worker. You might say, well, 1 to 100,000 or 50,000. Can we get that equation? Is there a net number within the country? Can we then have the configuration? So it is not about what we talk about private, but it can be more efficient, and the quality outcome can still be there despite the lack of resources. So universal coverage is not necessarily saying, can we have a British system, because the funds are not there yet. But I think ultimately we need to get to that where resources are mobilized globally. But I think African governments are struggling. We need to say, we will partner with you and advocate globally to say Africa needs more money and the global community needs to support that. But that's that campaign for us. I hope I've answered that, Joseph. Yeah,
Thank
I
you
mean,
so much.
exactly what you say. It's some of the political problems, but I think Gitinji Gitahi pointed out that even if they do this, the actual UHC capacity is not possible in Africa. You will not get. And then there's also the problem is that when the politicians decide to put 15% to health, it's going to land up in hospitals where it's not really the need. So I think that Abuja is not entirely the solution. We need to look at it much more carefully, and I think that's one of the problems in Africa is to highlight primary health care and to go beyond this to say how much do we want in actual primary health care, and that may be less than the full budget. And we may say rather you put a certain amount, even if it's 3%, but it goes concretely to primary health care. Where in Africa, you find that very little relative to the big hospitals get to primary health care. So I think we need to highlight this. And I think we've got a fantastic, solution. I think Joseph's got ideas. We need to float these kind of thinking broadly. And it's a document that we need to work with. Thanks. Sorry.
Thank you so much, Prof. Shabir, for that. Because truly UHC is a discussion that is always ongoing, and there are so many moving parts and a lot of need to contextualize and decide what to prioritize. Susan also comments that Cameroon also doesn't have insurance facilities, and it makes it difficult for persons with disability to benefit from any kind of financial aid that they're given. And Fumnilola comments that there's a gross shortage of human resources in PHC, and that makes it difficult to practice effective healthcare. And he's asking what can we do to improve this shortage. I think Marika, in answering one of your questions, you spoke to what do we do about the human resource issue, because the shortage is a problem that we constantly have. So what then do we do?
Can I expand a little, because I went a little bit off tangent about peer supporters there.
It's all right, go ahead.
Like peer supporters are critical, and I think that there are niche populations that that are really high risk and have multiple complex needs, where this cater is really necessary. But then generic mid-level rehab workers, I've also worked with them. They are exceptionally good, and where you have to work across sectors, you have to go and speak to the chief, you have to go and sit with the community, you have to go and organize the ID, go and plead with the police, all of that kind of stuff. You don't want to waste a therapist's time, and they're probably not the best person for the job either. And the community health workers, and Prof. Musa and I have had this discussion before, they are very thinly spread. They have a lot of other things to do. And the sheer amount of time it takes to solve some of these disability cases is probably not the best use of their time either. And then thirdly, around understanding of disability, like proper understanding and attitude towards disability. With the generic mid-level rehab workers, often the selection process is around you must have a relative with a disability or have close experience with it yourself. So I think generic mid-level rehab workers are also critical to the skills mix. But then the way that we are training our undergrads, our professional undergrads, is also very focused on the private practice first world model. And unfortunately, like that is, you want to have your course accredited internationally, you want to have people able to migrate, etc. You want to set standard, it is important. But it's not just therapists, doctors as well. People are not coming out with an appreciation for health systems and how to work to strengthen health systems and use information to manage your patient load and to prevent people falling through the cracks like that. And if you are going to continue to sit and wait for people to come to you and have this revolving door, it's a disaster.
Hello, sorry, Marika. Oh, you done? Sorry.
Yeah, sorry, I'm done. That's my rant.
Okay, all right. Yes, so thank you so much for that. I think there's no one solution fits all when it comes to the HR crisis that we're experiencing in Africa. So it's just a matter of coming up with innovative ways. What can we do with what we have to achieve the goals that we want to achieve when it comes to delivering service? Let me see. Joseph has shared in the chat a website link that you can go and look at 12 pillars of governance that he says helped with his country. And I think, do we have any more questions? No, at the moment, no. So, Prof. Shabir, go ahead.
Yeah, just a quick one. I think, you know, we need to actually be clear, because this is one of the issues we need to put into the policy document, is that whilst we are saying that there are different contexts, we should be sticking, and that context difference can allow the variation to occur in terms of the mix of different health professionals or different cadres within a team per population. So it could be a very different mix of team between, let's say, Botswana and Rwanda or Cameroon. But I think the principles are very important. And that principle is that there should be a hierarchy of sorts, which means we need a rehab worker, for full professional, at the head of a team or leading the team, with mid-level workers who are trained to be much more flexible, and then community health workers and potentially other peer parents, etc., being part of that mix. And that's just an instance. So the number of people, you know, each of those cadres per population would depend on the context, but the principle is there should be team-based care to a defined population in the way that suits that country, but still achieves quality. Because if you look at all these comments, you need that. And in Africa, there is a tendency to think, no, we don't have rehab workers. Well, let's just train these people to rehab workers, mid-level workers, and they will go out there and do it. And we've seen the disaster. Oh, better still, let's get community health workers. We train them in 2 weeks, and suddenly they're rehab workers. They go out there and nothing really happens. So I think we need to be very careful of saying the context may differ. The context doesn't. The problem is that the mentality in Africa is not to have a team well constituted based on the context of the country that is dedicated to a population. So there's no accountability whatsoever by health professionals, and the politicians themselves, they have no accountability. They just say, oh, well, they're health professionals, but they have not helped us to actually link up to a population. And the results will come out as Marika has shown, even in a constrained environment with the whole mix, that give professionals the respect, let them lead, and they will find ways to make things happen with the limited resources. Of course, don't abuse them, but I think that you need to work with them, and that we need to tell politicians, give us space and let us do it. We have these models and we can make it work, as Marika has shown.
And thank you so much, Prof. Shabir, for that clarification. And the emphasis, it's true, we need to be very clear when it comes to these issues. So on the chat also, we have a question from Yana. Yana is asking, is there a funding model for peer supporters or parent supporters in the current and envisioned healthcare system? And are you able to financially support the peer supporters at Manguzi? If so, how do you sustain it?
Okay, so I mean, the background is I got caught in the earthquake in Nepal and then landed up volunteering at a spinal cord specialist hospital, and worked with a peer supporter there, and came back and I was like, we're doing it all wrong. We need peer supporters. That's it. So we found funding from Discovery to train peer supporters. The training isn't accredited yet, which is a problem. ISCOS is working on an international accreditation for spinal cord injury peer supporters, which is great. It's going to be a couple of years in the making. For the parent facilitators, Malamalele Onwards has done a lot of work on it, but it's still not accredited. so that's the number one barrier to come across. Number two is probably the same issue that the community health workers are currently faced with, which is the regulating body. There is no current regulating body for them to register with, and then obviously the same with the parent facilitators and peer supporters. But besides that, yeah, we funded the training initially using Discovery donor funding, and then they worked as volunteers initially, and I think that when you're starting something completely new and you haven't refined your selection criteria yet, I think volunteering gives you the opportunity to weed out the good from the bad. So I think that happened. And then I used crowdfunding to raise money to get one of my peer supporters to Lusaka for the Africa Spinal Cord Network Conference, where he met other peer supporters from all over Africa. And that really was the spark that ignited. And he came back and he was like, right, we're forming an NPO now. Like, we're doing this. We're going to get it formalized. And through a contact with the Rachel Swart Fund, which is an NPO based in Cape Town that sponsors specialist wheelchair and seating devices for public sector patients that cannot acquire them through public sector. I made a link with them and they came up to our rural area, and I did a lot of community input work with them to say, it's all fine and well, you can throw the best seating device at the person, but really then what? Can they get to the school? Is their family accepting them? Are their heads still in a mess, And then Rachel Swart Fund started supporting our peer supporters and parent facilitators through stipends. So they work on a per hourly rate, which gives them flexibility with when they work and where they work. And this hourly rate is then covered through the Rachel Swart stipends, which are paid into their formal NPO. The NPO is it's above board, it's audited per annum, it's standard. Funding is always going to be donor funding is never a sustainable option. And I really think that incorporating them formally into services would be highly beneficial. Whether this is done through service level agreements at district or provincial level, or whether, eventually courses are accredited, there's a regulatory body and we go the formal route. I think it's a necessary step forward. It just is going to take some time.
Okay, thank you for that, Marika. Our next speaker, Mr. Jacques Chirac, is with us. Mr. Chirac, are you able to unmute?
Thank you very much, Mercy. Good afternoon to everyone.
Good afternoon, Mr. Chirac. Are you able to share your presentation?
It's a shame it's not quite complete because I had a messed up with my computer, but that I have handy so I can talk extemporaneously if you don't mind.
No problem. Just a short introduction. Mr. Jacques Chirac Awa is a development manager with the Cameroon Baptist Convention Health Services, the second largest provider of healthcare in Cameroon, with an outstanding reputation in providing services to persons with disabilities. He holds an MSc in Development Management and a BSc in Political Science and Law. Mr. Chirac has got over a decade of experience in designing and managing large-scale programs on disability, inclusive of development and rehabilitation in partnership with CBM, the Reliance Foundation, Humanity and Inclusion, and Hope and Healing International. He is a coordinator of the Reliance Foundation Inclusion Network, that's the Link Africa, and also a delegate of the CBR African Network. Welcome, it's a pleasure to have you with us, Mr. Chirac. Please go ahead and take the floor.
Thank you very much, Mercy. Good afternoon, distinguished ladies and gentlemen. It's indeed an honor for me to have an opportunity to speak at this very important event. I work with the Cameroon Baptist Convention Health Services, and I'm presenting on the topic mainstreaming disabilities in primary healthcare through system strengthening, public-private partnerships. Our organization has rightly introduced its second largest provider of healthcare in Cameroon. It was created officially in 1975. Our work in providing services to persons with disabilities can be traced back to 1952, when we set up the first leprosy hospital in the northwest region of the country. The years thereafter, with the advent of the Decades for Disabilities, also came along with an expansion of the scope of our services to include eye care, community-based rehabilitation, education for learners with visual and hearing impairment, physiotherapy, orthopedics care, mental health. Across these specific specialized services, we've also widened our scope to increase in terms of subspecialties. So within the framework of our work, we started CBRO precisely in 1982, and the years thereafter have seen the introduction of a model that accounts for volunteers and community-based rehabilitation field workers. However, the need for rehabilitation in a context which is shaped so much by humanitarian crisis is ever increasing. And we realized the presence of the volunteers we have in the field had shortcomings in two dimensions. First, in terms of capacity, which posed severe problems with respect to quality, but also the number of volunteers who were willing to serve in hard-to-reach and underserved communities in the context of a humanitarian crisis. In organization, in Cameroon, to be more precise, CBC is the only healthcare provider that runs primary healthcare. So we have a network of 53 primary health posts in very underserved and hard-to-reach areas where there are no government facilities. So we thought it's important for us to change the model. And in changing the model and shifting paradigm, we're going to reconsider capacity building in a good way. When we started far back in 1982 with CBRO, we had not designed nor ever had a chance to roll out an intensive, well-designed training following the WHO guidelines. We've had 2 weeks, 1 month workshops for volunteers, field workers were those who had amassed experience on the field in doing rehabilitation in the community over the years and transitioned from being field volunteers to field workers. But they had not received any formal training until recently, with support from Lillian Foundation, we've designed the first CBRO professional training course, which is being run in collaboration with our Ministry of Social Affairs and Ministries of Health. However, working through primary health care to close this gap meant identifying community health workers, introducing them to the training protocol we have for CBRO. And again, it was the short-term intermittent courses, 2-1 months training for community health workers to enable themselves as the first entry point into any rehabilitation activities we do in our communities. That meant as they serve at the level of PHCs, they are represented in health areas and health districts. Their scope of work was limited much to identifying and referring, whereas in terms of hands-on rehabilitation, the field workers who supervise community health workers and volunteers will come in to roll it out in line with the WHO guidelines. It also meant to us, in one sense, training primary healthcare workers, nurses and midwives on inclusive health. So to say, what should be the case if we are not able to invest enough in running community outreach clinics, which has been the vehicle through which we reach out with rehabilitation, with specialized rehab services to the most disenfranchised in the community. Funding for outreach clinics was dwindling down over time, but the presence of the PHCs was still there in the community, and so that offered an opportunity. So we're transitioning or shifting from organizing every year at least 52 outreach clinics, which took a month consisting of physiotherapists, orthopedic physician assistants, and psychiatric nurses to provide services to the community, to rolling out these services, passing on these capacities to PHC nurses through a series of workshops guided by the MHGAP protocol for primary health care in mental health, designing tailor-made training materials to train primary health care nurses in ear, nose, and throat, or ear and hearing care to be more precise, physiotherapy assistance at PHC levels, as well as assistant ophthalmic medical assistants, AOMAs, to provide basic access to eye care, ophthalmic care at PHC levels. So by training these level of staff with specialized trainings in the areas I've mentioned, who work at primary health care level, we could reduce the number of community outreach clinics we took into these communities, and rather ensure that there are clear linkages in terms of referral between the PHCs with minimal capacity to offer rehabilitation services and the specialized hospitals. Then, with that shift, outreaches were reduced significantly when PHC nurses do the routine consultations and identify conditions which their capacities don't allow them to respond to professionally. They will congregate the clients, and a doctor and the specialized nurses, say an ENT surgeon and a team of ENT clinical officers, would pay a visit to the PHC on a precise date to do consultations, and cases that needed surgical corrections would be supported to access services at base hospital. This shift in paradigm from running of a minimum of on average of 52 outreaches in consultation with community stakeholders, the district health services, traditional authorities, religious authorities, has moved away as funding reduced significantly to working through the PHCs to still offer rehabilitation services. And it's working in terms of the PHCs moving away from the traditional approach to providing primary health care to being able to provide inclusive health services. The needs for rehabilitation, the needs for access to services for people with disabilities at grassroots level is not limited to their accessing specialized services like the ones I've mentioned, but also being able to access sexual and reproductive health and other general services, which without those services being inclusive, constitutes a major barrier in terms of enjoying their right to health. So at PHC level, we have staff who understand the basic principles governing inclusive health service delivery. They are able to collect disability disaggregated data. Gender and safeguarding are a key part of the training protocol we roll out. So at PHC level through to our base hospitals, they are guided by policies and strategies to ensure children, women, and adults at risk are safe in whatever service they're benefiting from, be it rehabilitation services on one side of it, or the general package of healthcare which everyone else in the community should have access to. So in summary, this is the approach we had to use, and the role of government to make the public-private partnership have been in areas where CBC doesn't have a primary healthcare post, but where we find a government facility we work through the district service. We have a protocol of collaboration with the Ministry of Health at national level, and that covers for interventions we can roll out in collaboration with district medical health services at district level. And so we would liaise at that point with the district health service, train their staff using the same training guide consisting of skills in inclusive health, but also providing services in eye, ENT, physiotherapy, and community mental health. So that level of collaboration has offered lots of opportunity in terms of access, even at a time when funding has reduced significantly. Thank you so very much.
Thank you so much, Mr. Chirac. Let's give him a round of applause. Despite the technological challenges, he has shared with us the kind of model that they use in Cameroon. And I think there was someone from Cameroon who had mentioned they're really having challenges providing for people with disability. And I think this is one of the models that have come up to try and address that gap. So anyone with any questions, comments, and on what Mr. Chirac has just spoken about, please go ahead and raise your hand or put your comment in the chat. Oh, sorry, I was muted. Thank you so much, Mr. Chirac, for that wonderful breakdown and presentation on models that are working for provision of rehabilitation services at primary healthcare level. Anyone who has a question or comment, please go ahead. We'll begin with Prof. Shabir.
Yes, thank you. I think that was very useful from a different part of the continent, and we really appreciate getting a variety of insights from across the continent. Jacques, if I can ask, in terms of the format, is there a sense of the services you're providing to a defined population, a general population, or is it to a sort of set of patients? Can I understand how that is working for you, and how it operates in terms of the mix of different cadres within that team? I'm sure you can see my inquiry is always designed to help us to get to this clarity about the mixes of people to population, of workers to population. Yeah.
Thank you very much. It's our services are provided from the perspective of preventing, treating, and rehabilitating disabilities. That is the goal. And so we are reaching out to the wider community, first from a strictly public health perspective, to prevent. That would mean even when we design and extend health services to the community, we are looking out for two groups of people: those at risk of becoming disabled because of impairments and yet not having access.
Quickly stop you there. I think I understand it's very much a holistic service, but do you have a defined population? Like when you say community, is it a particular area in which you say, I know the number of people in that area? And yeah, just to know that you have a discrete population you're dealing with. Just that question is very important. Is it a particular area of place, and do you know that is the way the services you give and they're getting no services elsewhere? That's the clarity I'm just seeking.
Okay, yes, we do. We do have defined populations when we use the word community. In our analysis, we have a clear idea of the representation of health facilities in our community. And so we prioritize communities, populations that have little to no access to these services. Those are the ones that are prioritized and targeted. with these specialized services and investments in rehabilitation.
Okay. But is there like a number to the population? Is it 10,000, 100,000, 500,000 when you say community?
Okay, I'll put it this way. The population of Cameroon is 26 million inhabitants by fair estimate, and we are present in 9 of the 10 regions of the country. And we run these services in all 9 of the 10 regions, but again, prioritizing underserved communities. So in terms of estimate from numbers, I will not be so precise in giving that.
Okay.
But that would constitute over 60% of the population of the country that are in remote and underserved areas. Because you go to the major towns and cities where you have access to those services for those who can afford, but the cross-section of the population residing in the hard-to-reach areas are the majority, and there are those who benefit from work in rehabilitation.
Not a problem. Can I just ask if you, I know you said you hadn't completed your presentation, but like a PowerPoint, but if you could and share it with us, I think that'll be really useful. And I really urge if you could write this up in a way that we can try to publish. So if you want to liaise, I'm sure that, Mariki would love to be part of it. I'd certainly want to be part of it. So please link up with us. You've got, you've got our emails. So please feel free to reach out and we could try and work on something after you put the presentation together.
Thank you so much. I'm sure you'll do that before close of business.
Wonderful. Over to you. Thanks. Sorry, Mercy.
No, it's all right. Thank you so much. I really like the discussion today because we're getting so many different facets of how people are trying to address the whole problem of how do we provide rehabilitation services to our populations. And I'm really enjoying this discussion, and I hope you are as well. So just to continue the discussion a little bit in smaller groups, I'd like us to break out into smaller groups and have a discussion, have 3 discussion questions that we'd like you to answer within your groups. And you feel free to appoint a facilitator or a repertoire who can just jot down a few points that you discuss, and then they can report back to the main group after you're done, so that at least we can have a more one-on-one discussion and get a little bit more of what rehabilitation services and at the primary healthcare level looks like for everyone who is in this room today. So
can we ask if anybody wants to? Yeah, I think you're probably right now. You can probably start.
Okay. Welcome back, everyone. I hope you've had fruitful discussions in your groups. So I'm going to start with room 1, who will be giving us just a summary of what you discussed. Room 1?
I'll report what I can, what I've jotted down. And if any of my group feel like I've missed something specific, especially Jacques, I'm sorry I had a patient phone call during the last minute of your talk, so please just let me know if I missed something. Could you put the, okay, let me just call the questions up on the chat so that I am going to answer them. So we had Nigeria, Cameroon, North Sudan, and South Africa on our group. Everybody except South Africa basically had no rehab at primary healthcare level, although Cameroon was making some strides towards getting it there in certain areas. Most of the rehab was offered at secondary or tertiary level care. There were very few rehab professionals. Most relied on faith-based organizations within their countries to roll out CBR programs and and these faith-based organizations either relied on mid-level workers or volunteers, or provided specialist ad hoc outreach services with not a guaranteed follow-up service on that. So for instance, with like repairs or reviews or reassessments and things like that. So in South Africa, we have got 1 year of obligatory community service for all therapists. They get put in rural and underserved areas. But like all the other countries, if there is a policy, it's poorly implemented and poorly monitored. And the one hand does not necessarily speak to the other hand in planning. So in South Africa, for instance, 1 year you'll get a speech therapist, the next year you'll get 2 OTs, the following year you'll get nobody, the following year you'll get like 3 physios, which also then doesn't really build a service. It's not a complete waste, but it is a waste. In other countries, there either was no existing rehab policy whatsoever, or same story, it wasn't monitored, it wasn't implemented, and it wasn't costed or budgeted. The challenges faced in providing or accessing rehab services at primary care level were largely that there were none, and people paid a lot of out-of-pocket expenditure in traveling vast distances or had to pay for private care, normally in that case dropping out of private care and then developing secondary complications because they couldn't afford care. The other was just the sustainability of faith-based organizations, and donor funding is always tenuous. So this was not seen as a long-term solution, and rather a health systems approach, and garnering stakeholder support from existing healthcare workers, raising awareness, garnering their support, and really using them also as advocates to advocate for formal establishment and integration of rehab services within the country down to primary healthcare level. In South Africa, we're a bit spoiled. Our challenges are, sure, at least we've got rehab down to primary care level, but it's often fragmented, it's poorly managed and planned for. You often don't have the resources to provide outreach at community level. And there's also mid-level rehab worker training has all but ceased since about 2007, with isolated top-up training for specialist technicians. And yeah, then in your opinion, what needs to be done to address these challenges and improve rehab services at PHC level? The human resource argument came up again. Most countries do not have the human resources that are required, and probably no immediate potential of getting them. There were the same warnings were echoed that were in the previous chat, was around insufficient short trainings of mid-level workers or upskilling of existing staff, and then throwing them to the wolves, and not building effective primary healthcare teams and resourcing them appropriately to basically like continuously develop and strengthen these teams. So that was a major challenge that needed to be, if a solution was a lower cost solution, to look seriously at the concerns around that. And then advocating hard all the way to the top, as hard as you can for as long as you can, using patient and end user groups to also advocate, using WHO, partnering with them, partnering with the bigger organizations to also lobby. There's WHO 2030. They're they're raising a big campaign to get rehab services wider coverage in more countries. And there's a lot of resources available on their websites. They've got a lot of guiding documents as well, which countries can use, and a lot of African countries regard the WHO quite highly. So that's an opportunity. And then, yeah, from my perspective, also getting end users involved as service providers as well in niche areas. I think that adds a level of accountability as well as legitimacy, as well as sustainability to the whole package. And yeah, if any of my group could think of anything. Oh, the last thing was that on a problem based was that when you refer people upwards and treat them only at secondary and tertiary care, you essentially perpetuate the medical model. And disability is about the interaction between the person and their environment. So if you take them out of their context, you're hardly helping them. That was a strong point. Anyone else want to add on that?
That is a good reflection of our discussions. Thank you very much.
Thank you so much, Room 1. Those are very strong points, and actually areas that you have issues you have brought up. Room 3, would you like to go next? Room 3?
Hi. Yeah, hi, can you hear me?
Hi, Carol. Yes, we can hear you. Go ahead.
Thank you. Thank you very much. So looking at the questions, similar themes. So when we look at where the rehab services are provided, so we had members from Uganda, Kenya, Cameroon, I think in Nigeria. So for us, most of the services are offered at tertiary level. We don't have any other lower levels. When we look at the challenges, or we look at the number of facilities that actually offer these services and their distribution. So even within, for example, for me, I come from Kenya. I work in a spinal cord injury rehab. We have one in Nairobi. We don't have any in the other counties, and yet the service is needed down there. I know for the pediatrics, there's been a lot of discussion about taking it down, let's say for the kids with cerebral palsy. I don't know if those have gone very far, but those discussions were started. But as has been mentioned by the previous speaker, figuring out how to take these services down to the community where our clientele will eventually be reintegrated. So access in terms of the number of facilities that offer those, the number of people who actually qualify to provide these services, the quality of care that is given by the personnel who are assigned to work in these facilities, the issue of financing. So some of these facilities are not well supported. We know that it works well if a large chunk of the financing comes from the government, so the financing is not as good. For the people themselves to access the service, they're forced to pay out of pocket, and sometimes it's very, times it's pricey and accessing is. Then what else? I think those are the challenges we had in terms of accessing. In our opinion, what needs to be addressed? I think a lot of it has been said. For us, we thought about having these services reach the lower levels, have more people trained. So looking at our colleges and universities, the areas of training that we can, because it's usually a team approach in the rehab. So we can have these individuals trained, more of them trained, so that they can equip, they can work in these facilities to ensure that as they're being trained, they're getting the right quality of training. I think it also be important that these facilities are available for the students to get an experience, a work experience. I like the idea of getting one year volunteer. We didn't have that, but I think that can also work in addition to the practicum. In terms of financing is to lobby or to have advocacy so that the government can finance more of these rehab facilities, and also to figure out an insurance scheme. We have the National Health Insurance Fund in Kenya, so something that can give a sort of package for rehab so that the persons who need the services don't have to pay out of pocket, or they have access to subsidized services. So for my group members, that's all I captured in case there's anyone who has something to add. Thank you.
Thank you very much, Carol, representing room 3. Anyone from room 3 would like to add anything? Okay. All right, so for room 1, I'll just give a summary of what we discussed, which is quite similar to what room 1 and 3 have presented. So for room 2, it's still the similar themes, the whole issue of having primary health, having rehabilitation services not at the primary healthcare level, they're the secondary and tertiary. So we had a similar representation from the countries South Africa, Kenya, Nigeria, and Cameroon. And a common theme was there's no nationally organized way of providing rehabilitation services from all the way from the tertiary down to the primary healthcare level, and that is a challenge. And something else that came up was the whole issue of reliance on donor funding, because an example from Nigeria, where most of rehabilitation services are funded by foreign governments. So they're the ones who run the program, they're the ones who decide where, when, and what exactly they do. So that is actually a huge challenge. And in terms of solutions, similar discussions came up. And on health financing, one important thing that came up, a point that was made by Mr. Joseph, was the whole issue of how do we finance these policies? Yes, we need policies to ensure that primary healthcare has rehabilitation services as part of the package. We need primary healthcare teams working together to ensure these services are provided. And we have policies, and we should develop policies where they don't exist for such a service. But how do we finance it? So the discussion about the Abuja Declaration again came up with an example of Rwanda is the only country so far that is allocating 15% of its GDP to healthcare financing, which is still not enough. Most countries are not doing that, and they don't have enough money to do that. And their economies are not big enough to do that. So then what do we do? And then now the issue of taxes. What kind of taxes can African countries target? And you were given an example of ICT companies, which are actually generating billions. Can they be taxed in such a way that that can help support African country economies in order to support healthcare financing? So that is one of the remedies that was proposed. And on the issue of donor funding, an interesting point came up on how COVID-19 has affected how countries are going to respond to the whole issue of defunding from, winning was the word that was used, winning African countries from dependence on donor funding. But with the COVID-19 pandemic coming in, you find that most African countries have needed a lot of support from foreign governments to fight the pandemic, to get their populations vaccinated. So whatever efforts had been made earlier to try and win off countries from donor funding, they have retrogressed. And so that is something that African countries need to think about doing, even as we seek how to finance rehabilitation services, how to move them to primary healthcare services. So would anyone else from room 2 want to add anything to the discussion? I am not seeing any hands, so I'm assuming everything is okay. So I would like to request all the facilitators and rapporteurs for the 3 rooms, please type down your discussions and email them to Prof. Shabir. I think he had shared his email on the chat. so that we can have a documented record and add it to the policy document for AfroPHC. And there, so please send, Prof. Shabir has shared his email again on the chat. Please send the documented discussion to Prof. Shabir. We really appreciate that. And we are coming to the close of our workshop today. And on behalf of the AfroPHC coordinating team and the board, we just want to say thank you to our speakers, Marika the Swedenborg and Jacques Chirac. Thank you so much for making the time to be here. And thank you to all of you and all AfroPHC members for making AfroPHC what it is, and also for contributing to this important discussion. And for those who are not AfroPHC members, please make an effort to do so, because it's a community of people from all over Africa who are interested in advancing the primary healthcare and universal healthcare agenda in Africa. We have these policy workshops every month, and that will be posted in the general AfroPHC email. So please go to the AfroPHC website and register as a member so that you can get more of these information and how and when to join the workshops and also the CPD meetings. Prof. Shabir, would you like to say anything?
No, thank you. Well done to you. And I think the team that's been involved, it's really been a very, very useful discussion. I think we all appreciate that. I think just to mention that the web link at the presentations, documents, and the recording will be there in a few days at the link that I've just posted. If you don't get it, just go to the AfroPHC website and click on the picture, the advert graphic, and it'll take you to this, and you'll have that all now, and the recording in a day or two. Thank you, Mercy.
Okay, thank you very much, everyone. Have a lovely evening, and we will see you next time on during our next workshop, which will be advertised in the website. So thank you. Bye-bye, everyone.
Thank you, and bye-bye.
Thank you. Bye-bye.
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 Bye now.